kind introduction. My name is Alex Misono. I'm an interventional radiologist in Southern California, where I am Chief of Interventional Radiology at Hoag Health System, which is in Newport Beach, in Irvine, California. Do come visit sometime. I hope all of you will come hang out in Orange County. I do want to welcome you to our webinar entitled Confident Tract Closure, a Modern Approach to Post-Biopsy Bleeding Control. This webinar is brought to you by SinglePass in collaboration with the Society of Interventional Radiology. In this second ever Industry Insights webinar, we would like to share novel technology designed to change the way biopsies are performed. The SinglePass device, as you see here on the screen, is really the first of its kind, one-of-a-kind device designed to close percutaneous biopsy tracts. This reduces the risk of bleeding, saving resources, and improves patient care. And you will hear much more about that shortly. So as we go through this webinar, please do remember to use the Q&A function feature on Zoom to ask your questions, and we will address them towards the end of our session. This is a brief agenda for the webinar. And you already know me, but I did want to introduce my esteemed co-faculty today. So first off, we've got Dr. Harris Changazi. He is also an interventional radiologist. He is at Great Lakes Medical Imaging in New York, and there he practices the full spectrum of minimally invasive procedures from venous to arterial to obviously solid organ interventions, and he does a lot and a lot and a lot of biopsies. He is a University of Rochester lifer and is well known to many of you in the audience, I'm sure, because he's been on numerous back table podcasts discussing everything from techniques to building practices and more. My other esteemed co-faculty is Dr. Joshua Cuban. He is a widely recognized, internationally recognized expert in oncologic care in IR. He is an associate professor of IR at MD Anderson. He is the co-director of IO Clinic at MD Anderson and the fellowship program director at MD Anderson. And I think there's about 10 other titles at MD Anderson that I have not quite listed here. He trained at the Brigham, at Harvard, Baylor, and Brown before starting his esteemed career. So I'm very excited to have these gentlemen with me tonight. And let's get started first. Why don't we do a polling question? So I do want to ask those of you on the call, if you perform biopsies regularly, have you or your partners experienced a patient with a significant bleeding complication, let's say in the last year? And for that, I might say, did it require an admission? Did it require an embolization, intensive care stay, or perhaps a transfusion, something like that? So we'll have that pop up here, and I'd like to hear what you all have to say. I'm not seeing the polling question quite yet, but I do have someone saying in the chat that indeed they've had a complication in the past, renal biopsy. Someone chatted about that, and certainly for me as well, that is a common place that I get pretty concerned about having a bleeding complication. So let's actually move on, and hopefully the next polling question will be able to come on. I'm going to stop sharing now, and I would like to hand it over to Dr. Changazi. So Dr. Changazi, you are up. I'm going to stop sharing. You have screen control.
All right. Hello, everyone. I'm Harris Changazi. Just bringing up my slides here. So thank you for the very kind introduction, Alex. I'm a vascular interventional radiologist out of Great Lakes Medical Imaging. Just before we get started, I do have, multiple consulting agreements with several companies, SinglePass included. But without further ado, let's get into it. So just introduce the device a little bit. Alex mentioned this is a one-of-a-kind device in such that it's a thermal coagulation device, which allows for tract closure for currently indicated for 17 and 18 gauge coaxial needles. It's FDA cleared, CE marked, and a very easy to use device that I'll go into a little bit. We think of why is this an interesting potential problem to solve, that solid organ biopsies, both kidney, liver, and then expanding out to lung, etc., are high-risk biopsies. By SIR guidelines, they do have a pretty significant risk of bleeding, and that risk of bleeding can result in requirements for transfusion and embolization, which has morbidity, mortality, and significant cost associated with it. Of course, we minimize those risks with anticoagulation holds, blood pressure parameters, whatever there may be. But ultimately, a bleed is a possibility. If you think of, other mitigative strategies, it can result in prolonged observation periods for patients, potential hospital admissions, ER visits, reintervention, embolizations, which ultimately can result in significant cost added to a biopsy, which, quite frankly, is a relatively low reimbursing but highly valuable procedure in terms of the clinical direction of a patient's care. So, the single pass, one of the problems that it solved is that it allows for very effective tract closure by allowing you to essentially burn the tract closed rather than relying on something like an autologous blood clot or gel foam. This is an example image here. I don't think my mouse is showing, but you can see the red arrows pointing towards a cautery tract, and that's what the single pass cautery looks like on extraction. This is obviously a liver biopsy here, which is very different from autologous clot, which you may not be able to see at all, and gel foam slurry, which, really can gas out your image completely. And I'll show some example images later. Okay. When looking at single pass ex vivo, they've done research to demonstrate how large of a burn zone you get with this device in different tissues. I have mostly used it in liver and kidney. And if you look at this, you know, uh, average range of burn, you're looking at about a 1 to 2 millimeter burn in these organs. And if you look at the size of needles that we're utilizing with 17 gauge coaxial, that it covers that size. A little bit different from, gel foam, autologous cloud, et cetera, is that the device is a little bit adjustable. It's not a set it, forget it one thing. You can adjust how long you hold the device down to plug a specific spot, and you can adjust how slowly you retract the device. And so there is some technique and nuance to performing these with different factors involved. However, it's very easy to do and very easy to get a hang of. Okay. Um, just to update on the data that the SinglePass company is collecting right now, they've been running a registry which is currently enrolled about 270 of 1,000 planned cases. And the early registry results show that the overwhelming majority, nearly all cases have demonstrated a successful closure with the device. That many of the responders report that this seems better than their usual method of tract closure. And some responders are even reporting confidence in the device to the level that they're reducing the observation time for patients post-procedure. Okay, I'll talk about my personal experience at our site. It's been me and three of my PAs. I've been the overwhelming majority of cases, but in our about 40 cases, we've had no major complications, bleeds, transfusions, readmissions, etc. With the utilization of this device in both liver and kidney biopsies. We found that it's been a very easy learning curve. It's been easy to teach my PAs how to use it as well, and it's become a go-to device for us. And it allows us to sort of expand our ability to perform biopsies, not send patients away when they may have relative contraindications like hypertension above 180 systolic, or they forgot to hold their aspirin or something like that. They have transport difficulties, so it gives a more fluid discussion when we're having these talks with patients about the risks of these procedures. Also provides reassurance in patients with relative contraindications. So when you're in an inpatient setting and they really need a biopsy, but the patient's on aspirin, they can't be stopped, or dual antiplatelet therapy for a recent stent, I think this device does give us the ability to provide some additional comfort when performing these biopsies, data pending, of course. Okay, I just have a little short video here just explaining the setup of the device. You can see I've got a standard 18 gauge biopsy device here. This is the 18 gauge coaxial needle. I will go through this video just a little bit. So originally, a lot of people would set up the device by basically passing the biopsy device through the cannula and lining it up. I find that the easiest way to set up the device is essentially to take the cannula okay, and line the cannula up with this lure lock that's on the device over here. And by doing so, I can adjust the length of the device such that the tip of the device, and you can see the tip over here with a cauterized burn after utilization, sticks out just a little bit past the coaxial needle. I don't like to go too far beyond because oftentimes I angle my biopsy device and I don't want to just put the device into a tissue that may not have been biopsied. The key is to plug the access point, in my opinion, and the tract coming back from there so the organ doesn't bleed. And so this is what it looks like after I've retracted it from the patient. Okay. For clinical practice, I alluded to potentially expanding indications, and we follow SIR guidelines for anticoagulation and antiplatelet holds in all inpatients and outpatients. However, these are guidelines. They're not absolute rules, and there are many situations in which a biopsy may need to be expedited or otherwise fall outside of guidelines. Like I mentioned, uncontrolled hypertension, a patient with ascites where maybe you can't clear it completely and you need to do a targeted lesion biopsy. Inpatient biopsies, patient may have been on medication. That's a contraindication, but they've got to determine management for possible acute autoimmune hepatitis, whatever it may be. Um, all of these situations prevent these gray zones of, okay, do you hold a patient inpatient for an additional 3 to 5 days for an appropriate antiplatelet hold? Do you send an outpatient home to return another day? What if they live 2 hours away from a rural area? These can be, situations in which having additional reassurance that you're able to successfully close a tract may be helpful. So because of these sort of gray area presentations, we now utilize SinglePass on almost every inpatient biopsy and the majority of our high risk outpatient biopsies as well. And you could think of cost. The device is not very expensive, especially when you compare it to what an overnight stay in a hospital, let alone 5 nights in a hospital, might be for somebody who's awaiting a diagnosis and needs to hold a medication. This has many financial implications. I kind of jumped ahead for my slide here, but it allows us essentially the possibility of both expediting biopsies with shorter anticoagulant and antiplatelet holds in specific situations, and also allows us for a potential for increased throughput with lower post-biopsy observation times. In our practice, we've actually reduced our routine observation times down to about 2 hours, and oftentimes even 1 hour after using the SinglePass device with no adverse outcomes. If you think of what the potential advantages of this device are, just to reiterate, thermal coagulation is not dependent on clotting cascades. It does not flow out with the vessels like gel foam or clot may. And it allows us to image without artifact, which gives us better visualization of the surrounding organ, and overlying soft tissues to assess for potential bleed if it's present. It gives us that feedback, in real time. And the device is actually controllable, unlike, gel foam or clot where you might be injecting it and kind of it goes where it goes. You can reposition, you can retract, you can re-advance, you can adjust the duration and speed of retraction. So it's really much more finessed approach to tract closure. Last thing is, gel foam oftentimes, if you get a bunch along the capsule, it can be irritating and painful, and haven't had any issues with pain with utilizing the SinglePass device. So couple that with a shorter observation time, and this can really represent an improved patient experience as well. This is just some examples of what gel foam and shadowing look like. Okay, so you've got top image pre-biopsy. The leftmost image is a liver biopsy. Underneath is gel foam. You can see that the liver parenchyma and all that is obscured by the gel foam. And then I've got a renal biopsy in the middle there, where again the bottom image shows obscuration, and that really does become a limitation in my eyes of gel foam as well. Um, Here's an example of just putting the device in and utilizing it. So I've essentially got my coaxial needle in. You can see some blood dripping here. You screw the lure lock on, okay? Then the device has an on switch at the back and a button over here. Once the lure lock is tight, I like to flip the device over so I can press the button with my pinky and support the coaxial, making sure that, I'm watching under ultrasound and retracting. So this was a renal biopsy that I was doing. You can see the tip of the device over here. I'm holding down the button right now. It's currently on. There's a little bit of bubble artifact that arises from that, and I start to pull the device back slowly to help cauterize the tract. As we do that, patient's breathing, so it's moving around a little bit, but I can watch my needle come back all the way to the capsule and then out to the soft tissues as well. This is a little bit of gas artifact from the cauterization and the heat coming into the vein there, which oftentimes you'll see with gel foam. However, in this case, you can see that my image stays pretty clear, and I can see exactly where my tip is and what I'm doing and where I'm working. After the biopsy, the single pass device is removed with the coaxial. This is an example of what some of the tracks look like with single pass, and it's really a clean linear shot of a little bit of increased echogenicity without distorting the distal visualization or surrounding visualization, as you may see with other techniques. Here's an example of a case that I did in a patient with ascites, which, represents one of those sort of fringe cases where you may be hesitant about an increased risk of bleeding. And, this allowed for a really confident long segment tract closure of a targeted liver biopsy with no post-biopsy hemorrhage, despite there being ascites present. Okay. I alluded to post-biopsy observation. A lot of the literature shows at least a 4 hour observation hold. Some patients, even where I was in training, used to hold patients overnight post-renal biopsies, et cetera, because it was such a high-risk procedure. However, we've routinely been doing our biopsies, both inpatient and outpatient, with only 2 hours of observation, and in uncomplicated and low-risk patients, decreasing that observation time to only 1 hour with good anticipatory guidance for any potential complication. It allows us for an improved throughput, getting patients, through faster with better staff utilization, allows for a better patient experience because they're not sitting around waiting to go home. And in patients with difficult to control hypertension, et cetera, I'm reassured by good tract closure because you may give a medication to drop sedation or labetalol or hydralazine or whatever it may be to drop pressure, but what does that mean? 90 minutes later or 4 hours later when that pressure jumps back up into the 180s or 190s. I do find that cautery gives me a little bit more reassurance in that situation. Um, Same thing, not to belabor these points, we do follow SIR guidelines, but when you're talking about aspirin and risk, there are many situations in which you may not be able to or want to hold aspirin or Plavix or whatever it may be. And we routinely even recommend on the inpatient side in consultation that, in patients with recent strokes or whatever else, that we'll utilize this device to help mitigate the bleeding risk and document that formally after discussing with the referring teams and families. Minimizing delays in diagnosis can expedite care and help with decision making that may also have downstream implications on patients' outcomes as well, beyond just preventing bleeds, which I think is an important point to make. Okay, key takeaways from my presentation here are that I find the device easy to set up, use, and adjust. Find it effective. Does not compromise imaging and is very well visualized under ultrasound, and may allow expedition of care, scheduling, and throughput to help us take care of more patients in a safe fashion. So thank you for your time.
That's an awesome presentation. Thank you. Thank you so much. I have a couple kind of takeaways myself from that. First is whenever I hear you talk, Dr. Changazi, I always learn something. You got a lot of clever ways of doing things as well, like your pinky. I don't think I can do that myself, but it does go. But it just shows how creative you are in your approach to that. So that's really amazing. The second thing, thank you for the call out for the Be Safe study. And I think that's a very unique way to get physician experiences into the registry. And I know all the faculty on the call have participated and are participating in that, just so we can get the data and the experience to show how well it's functioning in real life. And so, those of you on the call who are starting to use the device or maybe interested, hopefully we can get you involved with Be Safe as well. Again, as you learn, certainly you could be in service on using the device and so forth. So you can figure out your special way of doing it if you're not as coordinated as Dr. Changazi is over there doing gymnastics with this device. So I actually do have one or two questions for you. I mean, I was really struck by the your ability to reduce the amount of time you're holding patients. I mean, that's insane. You're in some cases having the recovery time of patients. I'm curious, what's been the perception of that? Have you seen improved, like actual improved, like your nurses? What are they saying? Is administration interested in the things that you're doing? Do you have plans to bring it to administration and say, hey, look what we're doing. You can schedule more cases, things like that. I'm just kind of curious. You're ahead of the curve on this one. So curious what you're doing with it and where you're going with it.
Yeah, so I think as far as administration, they just see our year over year growth in volumes. When you
Mhm.
when you look at, we're a private practice group that covers a hospital system. In the outpatient side, throughput is paramount. And so on the outpatient side, the device is more expensive relative to the reimbursement. But if you can get through 4 times as many patients in a day, the math changes a little bit.
Yeah.
Similarly, on the inpatient side, I think the cost it becomes minuscule, especially if it allows us to schedule patients later in the day, right? If I have a patient that comes in for a 2 o'clock biopsy and only needs a 1 or 2 hour period, that opens up my ability to accommodate patients around their work schedules and whatever else, and allows us to offer more slots. The shorter biopsy times also. Allow us to do more patients in a day altogether, and it allows us to stagger the way that we schedule patients such that we can optimize our schedule much more. It gives us a lot more flexibility. We haven't formally taken this to administration, but administration very much so follows what our outpatient volumes of procedures are. And I think we're up, like, including other procedures, of course, like 30% year over year. And I think a good portion of that is the biopsies that we're able to get in very rapidly and get out very rapidly without having complications.
Yeah, I mean they take up, I mean for us they just take up beds, right? And these are pre-post beds, recovery beds, and the quicker we can get them out, the more patient throughput we can achieve. It's a good, I'm like literally taking notes as you talk. It's a good webinar when you're taking notes as you're answering questions. So I have one more question for you, which is, you talked a lot about these, kind of pushing the envelope, right? There's guidelines and then there's real life. And you're pushing the envelope there. I'm kind of curious about, so that's impressive, in and of itself. I was wondering about the other side of it is, does the device allow you, let's say, to take bigger cores than you would have otherwise, or practice with more confidence, or practice with what, kind of like better patient relationship almost because your risk is lower, less stress, you're less likely to get called back at night for an angiogram. Can you talk a little bit about that?
Yeah, so I mean, I think it allows me to do biopsies in situations where I otherwise would have sent a patient away. Oftentimes we have patients that were on clonidine and they were told to DNPO for sedation, and they don't take the clonidine and they show up and their pressure is very high and difficult. And I think, our referrers find it valuable that we're not just sending patients away multiple times. In patients that are new presentations and might be hypertensive, it used to be my practice that, okay, no, you need to go back, you need to see your PCP, you need to have your medications optimized. And I routinely do these biopsies now with higher pressures, a little bit of sedation, and without that concern. Um, you know, Guidelines wise, the way I think about it is oftentimes you're put in these scenarios in the inpatient setting where you're probably going to end up doing that biopsy anyway because some ICU doc or some other, physician is telling you, look, I absolutely can't do this. We need to know what's going on. Can you please do this biopsy? And it's like, well, if I'm in that situation where I'm going to have to do it anyway, why not use this to mitigate the risks to the patient? And it's been very successful for me. The last thing I just want to comment on is with the gymnastics in my hand, it took me some time figuring that out. But I will say that initially, when I was using the device, I did it with my thumb. I found that the connection. Once you figure out how to lure lock it on there tight, you can pull back the device just holding the device, and the coaxial comes back. I just like that added sort of support. I think it makes for more reliable ultrasound imaging. So.
Yeah, it's all physics at the end of the day.
Mhm.
All right, so let's do another polling question. Then I'm going to hand it over to Dr. Cuban. So, Dr. Cuban, get your slides ready to go. But I have another question. So, have you had a patient where you, and this actually builds on Dr. Changazi's discussion, have you had a patient where your referring doctor has canceled or postponed a biopsy because of a perceived bleeding risk, let's say within the last year? So, we'll let a couple of these responses trickle in. Let's see how it's going. I'm seeing the preliminary here, so it's pretty interesting how this is shaken out. Please do respond. We would love to get your thoughts. Give it a couple more seconds because we got a lot to cover. But I'm getting a sense of what's happening here. The trend is pretty clear. So let's end the poll, and then we'll share the results, which is a resounding yes. So 95% of you said yes, and I got to tell you, I couldn't vote because I'm a moderator, but I would have voted yes on this as well. So I would like to now pass it over to Dr. Cuban. And so the stage is yours. Thank you, sir. Welcome.
All right. Thank you for having me. It's here to talk about biopsy tract closure. Take a little bit more of a step back than really focusing just on the device and really talking about is there a need for this and a little bit of my journey of how I found this. So those are some of the things that we'll go over. My disclosures. So a big question, do we need tract closure at all? And I think we'll spend a little bit of time on that. We'll look a little bit about SinglePass, my experience with it, and then some discussion about the potentials and unknowns and kind of what's ahead for this device, and a little bit of a summary. So do we need it? This is a slide that we've seen earlier. Really is not surprising that we know there's like a 10% chance of minor bleeding for kidney liver and much smaller, but for major bleeding. But there's a big difference between these. Minor bleeding, some pain for patients, but usually not a huge problem. Major bleeding, a huge problem for patient safety, patient satisfaction, and obviously costs. ICU stays, embolizations, etc. But minor complications also do have costs. So especially if you're doing this in an OBL and you end up having to transfer them to someone to get more labs, or you end up keeping them overnight or for a longer period of time, there are some potential costs that add up for this as well. But really, for anyone that's doing a lot of biopsies, they know that there's biopsy, that bleeding is a huge problem. Not in a lot of patients, but when it happens, it can be a really big problem. So I think what most people use, what I've used for a really long time, which is gel foam, either like a slurry or pledgets. It's really what I've been using for the last 10 years and what I learned in training. And the reason for that is that it works really well. There's some studies out here. It's not a great thing to publish, but really these studies are done really well, looking retrospectively at the last 500 patients. And this is a group that uses slurry through their needle, and it's pretty obvious when you use gel foam, even when you're selecting patients you're using it for, which is not randomized, you still have a much lower incidence of both minor and major bleeding. So I think it's useful to use, obviously, tract closure in general. Do I use it for every case? I don't. There are some cases where the needle is just totally dry and I'll just pull it out. I have senior partners which do use it for every liver and kidney biopsy that they do. And I think my threshold for using any kind of tract closure has gone up. If like every other year I have some liver embolization I have to do after a biopsy, probably just kind of creeps up my level of when I want to use this. And I probably use it more often than not if I have really any reason to do it at this point. I'm doing tract closure. So ascites, any significant bleeding that's coming through the needle, any hypervascular tumors, coagulopathy, thrombocytopenia, any of the medication holds, hypertension, I put on here, but that's a great one as well. So this is really what I was using for a long time. And what brought me to this device is that about 18 months ago, we had like two small M&Ms in a row. And so not great, long data, but I was like just looking at them. One was a spleen where gel foam was used and came back, I think a week and a half later with like a terrible splenic abscess. So I think this is kind of super rare. I've done gel foam like a lot of times that hasn't happened, but it's just something that gave me pause. But it was like very strange. The next week that came, there was another case. I'll just show it to you here. This was a mesenteric biopsy. You can see the mass just in front of the cava there. And then, so there's a needle going into the biopsy, not my case, but I saw some M&M. Moderators don't have complications, just their partners. And then you can see a little bit of a gel foam was injected, a little bit of air here. But on the table, the patient got terrible abdominal pain. And so we, at some point, there was multiple non-con CTs and no bleeding, what's going on. It was really exquisite. They got a CTA, and this is a little bit of a MIP, but those are the veins behind. The artery actually cuts off. So this was real life embolization of gel foam going into branches of the SMA. And you can see in this angiogram, this trunk here is really like cut off with most of its major branches. Multiple, embolectomies were performed and got it better, but like ileocolic still doesn't look good. Still some issues. Patient ended up doing fine, was anticoagulated. This is like a big problem. And just like these two cases happening like right after each other, it just got me thinking, got me looking at like ways to fix the problem we were seeing and studying a little bit. Some things have been published about gel foam going places. I'm not trying to trash gel foam. It's a great thing. I'm not like trying to say it's not good, but for some reason I started these things all happening at once got me thinking about what alternative could exist. And the first thing that got me thinking was, all right, I do a good deal of microwave ablation and I put probes all over the place and I almost never have any bleeds. And because I cauterize my tract. So that moment, I was like, I'm going to invent a needle that is going to cauterize my biopsy tract just like a microwave. And I was like talking about it, sure I was going to be a bajillionaire. And then my friend Taylor was like, "Oh, you mean SinglePass?" And I was like, "Yeah." So I found out what the device was, and it's essentially, it's like everyone's had this idea, I feel like, and it's a very simple device. It's just a cautery that goes through a needle. It's not very fancy. There's not much to it. No offense to the SinglePass folks, but it is just a very simple device for a repetitive problem that makes a lot of sense. Changazi talks a bit about how this works. I do a very similar thing. I don't have any videos of me using it, but I line it up to the coax needle beforehand, lock the lure down, lock the blue stopcock down that puts you where on the needle you want to be. Do the biopsy, take out the stylet, and then put the SinglePass in and cauterize on the way back. And so it's really the simplest devices. It goes through your coax needle, heats about 60-ish degrees as you remove. So I was ready to try it. My first experience, I wanted to have a case where I actually had like some pretty cool imaging that I wouldn't otherwise have, which was I had to do biopsy plus mapping on a left lobe. And so, good sized lesion. And he was under, it was actually going to start with an ablation, but it gotten too big when I got there. So I kind of converted to biopsy. Instead of biopsy ablation, I was going to see biopsy Y90. So the patient was under GA, liver was high, did have to do like a CT approach going up with his high liver. There's my biopsy, great. Do my angiogram, inject MAA. But part of my mapping, I actually got an in-room CT just so I can do my MAA calculation. And as part of that, I get a really nice image. And so I got this image, not like intentionally to do this, but I was like, hey, this is actually pretty sweet. So I used the SinglePass and this biopsy device, and I had a really like it almost looks like I did an ablation. If you could have tricked me, you've been like, this is an ablation zone, and this is my tract cautery, because it looks just like it does when you do microwave. So that was just a really good example and a good first case for me and some of the ascites to be like, hey, this really worked. I have good imaging evidence that it worked. And so that was something that really caught my interest after that. So I started using it. And you can see it just really personally like matches perfectly to my needle. So additional cases, I think they've gone very well. But that's the really hard part about a device that's meant to stop a very infrequent occurrence. A small case series or personal experience using it, it's just not powered enough to figure out if it's really going to work. So I'm glad SinglePass has invested in this registry. I'm glad people are putting cases on it because it's really only with that amount of information that we can determine if this works for a problem that doesn't occur that frequently. So have I used it in every single case? No. And not every single biopsy. Someone asked if I use it in lung. I have not used it in lung. I'm just kind of learning how it is for liver and kidney. And I still use the BioSentry for lung. It may have a use there, but I do not use it there. So I use it anywhere I'd pretty much used gel foam before. Is this going to permanently replace gel foam for me? It might. Right now, I'm learning it, so I'm kind of using it anywhere I would have like used gel foam. I want to see what these results are. But I think it has the potential to be something that could be very good in terms of some of the other effects it could have, which we'll talk about. But I'm really using it anytime I'm worried about bleeding or seeing bleeding in my needle. From a technical perspective, as I said, it's very simple. There's really only one variable to mess with. So being a good IR, I've been messing with that single variable. So I've been trying to figure out how long I need to stay in each position. When do I come back faster? When do I come back slower? If you compare this to tract cautery from like a new wave, you have a thermocouple. So as you're coming out, you see when it hits 60, come back, so you don't have that here. So I've just been kind of messing around, coming back a little bit, actually pausing it, earmuffs to the SinglePass people. Take it out. This is kind of off-label discussion. See if they're still bleeding. One time I did see that, I kind of put it back in. I went for 20 seconds and then came back, tried again, and it was cauterized. So I don't think you need to do that in every case. I'm just kind of like tinkering with it and learning it. I've used the 10 seconds per 1 centimeter for all my cases, except for a couple that I've been tinkering with, and it's worked well. I haven't had failures. I have seen other people on the, there was a 98% have failures. And so I think we need to learn more. We need to gather more data. But from my experience so far, it's been really well, gone really well. Okay, so some potentials and unknowns. Again, with any new device, there's going to be questions about how dependable it is. It's been dependable for me, but we need to see how that is on a large sample size. It's a very safe device. I don't think it really has the capacity to get much further than a millimeter or 1.5 millimeters away from your cautery device. So I think from that perspective, I'm not super worried about it. You can see it very visually as you approach the skin, turn it off. But efficacy is going to be the big question, and how it compares, and does it really offer an advantage over something like gel foam. So this is where I would say I would encourage you to try it, because we need to know that. So the more people that are using it, get involved, get a little bit of training. It's really not difficult. A little bit of training, a little onboarding, use it, see how it goes, record what happens. And in doing that, I think we're going to learn what this device can really do. So I want to put in a plug for this registry. So protocol adjustments, I think there's a lot of potential for changing protocols. And as Harris was talking about, this is probably one of the big upsides to this. Do we need as much protocol in the periprocedural period in terms of holding anticoagulation, transfusing platelets to get to 50? What's the target INR if you're using SinglePass? I saw that note that you had in Epic. It said, hey, we don't care, continue the aspirin. We will do this biopsy with Tract cautery. That's pretty powerful. So hard to quantify, but it does need to be quantified, because those things are important. I think, do we need to do paras for liver biopsies anymore? Do we need to watch them, you were saying down to 2 hours? You can kind of think about this like what we did with AngioSeal and other vascular closure devices. Used to be a long hold in the suite, used to be a long watch time and then send home. And those really have changed the way we do things. So protocol adjustments can certainly be something that would be useful to see. And that does bring exactly to cost effectiveness. So the best analogies to this are going to be AngioSeal and BioSentry. And those devices both increase the nominal cost of a procedure because they cost more money to do it. They were optional, but both of them are used very routinely now, because they had not only effects on patient care and you're preventing those complications, but those actually had costs associated with them. So I think we need to look at these same things for this device. Are we able to change those things safely? I can't start with just like discharging people faster at a place like MD Anderson. Everything, if I want to like change my hat, I have to go through the IRB. So I would like to see that at other places and like to see what they're doing. But I think it's certainly something that needs to be looked at, and how cost effective can this device be? Because I think it does have the potential to change some of those things. So the next one is really kind of what could be indicate, like what kind of other things could we look at for modifications or indications in like a next generation device with something like this. Makes you think about like Tract cautery for organ access, portal vein work, other things that you need to cauterize. I think it's probably too small for what we need to do now, but I think that's something you could look at in the future. And there's this whole other topic that I'm kind of worried to bring up, which is tumor tract seeding. I don't think you can take tumor tract seeding to the bank that, hey, this is the reason to use this device. We know for HCC, for RCC, it's like fractions of a single percent or even less than that. But there are other tumors that have had higher rates of that, maybe colorectal and liver, certain sarcomas. Listen, I wouldn't use this just for tract seeding, but I bet everyone here has been asked a question by a patient, hey, how do you prevent the tumor from spreading when you take a biopsy? And it's very easy for ablation to say, oh, I cauterize it on the way out. I've literally said that a bunch of times. I'm not saying to use it for that, but this is something that you can say that does add a little bit of value. But I don't think this is going to be the thing that gets everyone to use this, but it's a potential thing to look at and maybe look at down the line and start studying a little bit more. But the bleeding risk is the main thing. This would be almost the secondary. So those are some of the things I'm interested in seeing how the device develops and what potential it has. So in summary, I came to this device because it is such a simple solution to a repetitive problem, and I was seeing issues with alternatives. And that's what we do. We look for cool new things to play with that can treat patients better. Could I say that this is going to be the end-all best closure device of all time? No, I don't have enough information to say that. But I do think it has the potential to be something that's very different from what we're used to, and to do what for solid organ biopsy, what AngioSeal did for vascular closure, and what BioSentry did for pleural punctures. And because of that, I'm interested in contributing to the registry, learning it, and then getting all that information out so we can see what the full potential of the device is. And that is all I have for you guys.
Thank you, sir. That's super interesting, thought-provoking. Again, taking notes while you all are speaking. I also learned a few things I loved. Moderators don't get complications, just their partners. That's awesome. But really, what I thought was incredible was those complications that you shared. I mean, kind of, yeah, I mean, almost unbelievable complications that we know are theoretically possible, but basically never see. So that was quite fascinating. Um, and then tumor spread or tumor seeding and I think I would counter and say, well, I think that one of the biggest risks of tumor seeding, and I'd love to hear your thoughts. My personal opinion would be the biggest risk would be bleeding. So like I do a kidney biopsy for a mass and it bleeds. That probably by itself is the single largest driver of seeding, not like cells on the needle necessarily, but actually that act of bleeding. I'm curious, you're obviously kind of a world expert in this space. How would you respond to that?
Well, I don't think I'm a world expert in tumor tract seeding. Let's at least hope not. But I hear what you're saying. Spread the easiest way to spread tumor is through bleeding. Most tumors don't obviously have the ability to set up and grow. And then there have been some studies that look at even the patients that do get tract seeding, it doesn't like clinically matter for them. They end up getting on the same therapy. It doesn't really like change what their course of disease is. If I was a patient though, I don't know. I wouldn't want a tumor like a tumor in my tract. So I think there have been cases I have seen it infrequently. I see it more through GI, probably because they don't use coax technique, like through the stomach for pancreas. I've seen that a lot more commonly. But I have seen these tract closures, I think, in something like a sarcoma, which I think has a little bit more propensity to be able to grow. It really depends on the tumor.
Hmm.
And I think there has been some, like, meta-analysis that colorectal cancer, in particular for liver mets, has a little bit higher risk than certainly primary liver cancer. So, we're seeing lots of younger and younger patients getting these colorectal liver mets, and we're, extending their lives a long time with all these different local therapies and systemic therapies. And it may actually bring out some of the previously irrelevant tumor tract seeding as we start to control more local tumor. And now we're continuing to grow that out. We might actually see that it makes a difference. So I don't think the data is there to support using this for tumor tract seeding. So I'm not trying to sell that, but I do think it's intriguing.
Understood.
I
Understood.
do think it's intriguing. Like
Yeah.
for me, I'd want it. Like it makes sense to me as like someone that if you were getting something, I know a patient it would be like great for patients, but I don't think there's data support yet. But I'm like really intrigued that there might be, and I think it's worth studying.
Yeah. I mean, if I was a
Especially
patient
as a
getting a
secondary
biopsy,
benefit. Yeah.
if I was a patient getting a biopsy, I'd probably bring one with me and teach them how to use it, so that they can use it to close my biopsy tract.
I'll come fly
Yeah.
out, Alex. Don't
Yeah.
worry,
Yeah.
man. I'll
Thank you,
come get
sir.
you.
Thank you,
Yeah.
sir. There are some interesting questions in the chat as we close up. I do want to address the ones that we can get to. So one of the questions in there, curious both of your thoughts. Thermal injury from repeated biopsies. Let's say a transplant patient who's getting multiple biopsies in a year. Would you be concerned about thermal injury from this thing, from repeat tract closure? Dr.
I mean, I
Changazi?
guess oh, go ahead.
Yeah, I mean, I always wonder about that because, nephrons being one of those things that don't regenerate and how frequently we do these biopsies, like every time we're removing cells. I imagine that the damage from the biopsy itself may be larger than the tract. But I don't worry about it too much. One thing, go back to an earlier question, and it is relevant here. Alex, you'd asked about potentially doing fewer passes, using a larger gauge. I do 16 gauge biopsies now on most of my kidneys. I find that I can do just two passes with a similar bleeding rate as reported in literature. And the single pass, if you slow down the rate of retraction, still seems to be effective in closing that tract. Um, yeah, that's my response.
Got it. Dr. Cuban, any thoughts on thermal injury? I mean, it's a pretty tight band of energy we're delivering, right? So, but you
Yeah.
work at a major center, transplant center.
Not a major transplant center for renal stuff. We work with someone else for transplants, but so
Okay.
mostly um, we don't see a ton of repeat kidney biopsies. Like we have someone that has it, and but we don't do it over and over and over because we're not a kidney transplant center. In liver, the only thing I would think about for thermal injury would be like, if you're super central and you went through a duct or really close to a duct, are you like potentially injuring that on the way out? I think the way the device is set up with how small it is, unless you're really taking a weird approach, I wouldn't worry too much about it. You'd have, if you went that close to a duct, you're that close to an artery too, so you might have bigger problems, which hopefully this would help fix. What I would say though, if there was like a next generation of the device that I think has been talked about or making it bigger or more powerful, then I think the safety starts to become an issue. It's pretty like safe now. I don't feel like you can make a lot of issues. But as you get more power, you start actually getting ability to do some more harm. So I think right now, not a lot of concern, but maybe if there was a future more powerful device, I would be.
Can I
Interesting.
can
Perhaps
I
there'll be
add
different types of devices for different uses. Yes. Oh, yes, Dr. Changazi.
one more point about that is just, if you think about, kidney biopsies, we do cover a transplant center that does a good volume of these. The most dreaded complication is the page kidney. When you have that subcapsular bleed and it compresses the kidney and then you lose the function pretty rapidly, and those can be pretty difficult to manage. So I'm more concerned about stopping bleeding than that
Hmm.
damage.
Yeah,
Thank
that
you
makes
for that. Yeah, additional context. And then another interesting question, and I promise we'll close soon, but I do want to address this. I know Dr. Cuban, you don't use it in lung. Dr. Changazi, any experience with lung with the device?
I've done a couple of mediastinal masses because
Ah,
I'll use
okay.
18 gauge there. But for lungs, I'm typically doing a 1920 gauge system, and the single pass is too large for that, so I don't have any experience with it.
Okay. I'll have,
But yeah,
actually, well, I'll answer that question, which is that I
mhm.
have used it in lung. I've actually used it a number of times. So I'm also a 1920 person for lung biopsies for the most part. And this device is rated for 17, 18 gauge systems. And we hope in the future iterations there will be smaller devices specifically designed for 1920. But right now it's a 17, 18 kind of system. So 17 gauge guide needle is typically what this device will fit through. But I will say this, which is that when I have cases of ground glass nodularity, GGOs, difficult to get tissue sometimes, difficult to get diagnoses. I will grab my 1718 system and I will single pass it on the way out such that I can get a really nice big core, take one or two, limit the number of passes, limit the hemorrhage in the biopsy sample. Pathologists seem to have been quite happy, and I've been diagnostic every single time I've done that. So I will finish with that, and then actually I'm going to go to the end. So we've actually kind of made it to the end. We do have a couple summary points here. We do believe, I think we've really come to conclude tonight, bleeding complications are really all over the place when it comes to the world of biopsy. And we believe this is an innovative technology that is very well attuned to stopping bleeding in the biopsy tract. And of course, we're working on the data, we're working on the science, the clinical results, tracking that. And so, Dr. Cuban, thank you for pushing the agenda for Be Safe as well. But if you want to participate in Be Safe, please do contact the SinglePass team. Scan that QR code for more information as well. And I know all the faculty on this call would be more than happy to hear from every single one of you in the audience to follow up and have further discussion. So I'll close with that. Thank you so much, Dr. Cuban. Thank you so much, Dr. Changazi, for being part of this webinar, and have a nice evening.
Thanks everyone.